Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Giovanni Zucchelli is a professor of periodontology at Bologna University, Italy. He holds both a doctorate in dentistry and a PhD in medical biotechnology applied to dentistry. In this presentation, he provides his overview of treating gingival recession associated with non-carious cervical lesions.
Hello, my name is Giovanni Zucchelli. I'm professor of periodontology at the University of Bologna, Italy. And I'm speaking about the treatment of gingival recession when they are associated with some non-carious cervical lesion that very frequently occur at the buccal aspect of the cervical areas of the teeth. We have different types of non-carious cervical lesion, and some are shallow or deep, but they belong only to the root surface, while most of them belongs to the root and to the crown. And when they belong to the root and to the crown, the treatment plan is completely different. There are also non-carious cervical lesion that belongs to the root and the crown, but since the support of the soft tissue it's so apically displaced that most of the therapy is done by the restorative dentist. And finally, there is another type, which is called 5 type of non-carious cervical lesion, which are also called abfraction, which maybe are due to some occlusal trauma, which can also need some periodontal treatment to be performed in the right way. And this has been summarized in this article of 2011 that we wrote together with my group, and we tried to classify different types of gingival recession associated with non-carious cervical lesions. So we have shallow root abrasion, deep root abrasion, deep non-carious cervical lesion starting from the enamel, shallow non-carious cervical lesion starting from the enamel, and carious cervical lesion associated with gingival recession and loss of bone and attachment. And finally, as I told you, the abfraction. The treatment is different according to the type of non-carious cervical lesion we have, and not on the type of gingival recession we have. So we have, for example, that the coronally advanced flap can be performed in the presence of shallow root abrasion, bilaminar technique in the presence of deep root abrasion, while we will discuss more in detail the treatment of those complex situations where we have both loss of hard tissue at the level of the enamel, together with loss of root substance at the level of the root. And this is in particular the type 3 and the type 4A that I'm going to discuss in more detail. The type 4A is a specific type of lesion which is very, very frequently we can meet in our clinics. And if you look at carefully where exactly the line of abrasion gets inside to the papilla, this is much more coronally displaced with respect to the cement enamel junction of the adjacent lateral. So nobody in the world would like to have a canine that is shorter than the lateral in a soft tissue margin, because this is not aesthetic. Everybody would like to have a canine whose cement enamel junction is displaced a bit more apical with respect to the lateral incisor. And that's why we have to rebuild this new cement enamel junction by a restoration. And this restoration can be performed very easily because of the presence of the gingival recession, so we can use the root exposure for the clamp application, the rubber dam isolation, and to make the composite restoration. And this composite restoration is done exactly in the same way as the natural cement enamel junction, so it's a bit over-countered and a very, very convex surface, but smooth, clean, and it's a perfect surface onto which we can adapt our keratinized tissue of the coronally advanced flap. The keratinized tissue is like a cord. It's a tissue that is made of a very hard, collagen-rich connective tissue that we can tightly, very, very precisely against a very convex, smooth, and hard surface. That is the composite restoration. In such a way, you can block completely the attempt of the blood, because at the end of the surgery, we still have blood, not blood clot, but we can block our blood from seeping from the soft tissue margin. And so the blood that is accumulating inside the soft tissue from the soft tissue and the root, especially if you have some concavity of the root, has a right space to stabilize. And when the blood can stabilize, can become blood clot, and when blood clot can start to mature, can become new connective tissue. And that's why now you can see that after a few months, also the soft tissue becomes convex because of the maturation of the connective tissue from the blood clot together with the thickness of the connective tissue of the covering flap. And so we start to have a very good emergency profile, which is easy for the patient to clean. And as much as the time passes, this thickness increase, and by increasing in thickness, there is also the phenomenon which is called creeping, even if it's not really attachment, but thanks to this creeping, there is a further growth in thickness and in coverage by the soft tissue of our composite restoration. And so we have a good emergency profile, but if you look exactly where we have covered this root, it's not exactly where the patient was expecting at the beginning of the surgery, because this line was for the patient the cement enamel junction. So the patient was expecting to cover this line because of the difference in color between the crown and the root. But this is not what we really want to do, because nobody wants to have a cannon that is shorter than the lateral, because nobody wants to have the cannon that is shorter than the premolar. And so when you look at the picture from the buccal aspect, you see that all teeth were covered in the right way. The cannon is a bit longer than the lateral and the central and then the premolar, and this is what the patient like, even if he doesn't know from the beginning if that famous line that was too straight was the cement enamel junction or not. It's us that have to change patient expectation by moving the cement enamel junction of the patient from the cement enamel junction that is ideal from an aesthetic point of view. But in order to understand better this concept, I would like to show you the so-called sleeping tooth. So you see this tooth that is very, very long, is like sleeping, because it tells you very, very well what is the difference between the over-counter of the enamel with respect to the under-counter of the concavity of the root. So if we displace our flap in corner direction and we try to adapt it very, very carefully to the convexity of the enamel, and if you look by transparency where is the abrasion defect, you can imagine that in the case of even a very, very small shrinkage of this flap, it can collapse into this hole. And that's why this is very dangerous, because it's very frequently that after coronally advanced flap, there is a minimum shrinkage of soft tissue. In order to prevent this, what we do? We make our composite restoration that leaves a very convex, regular, and very, very smooth and hard surface into which the keratinized tissue of our flap can be adapted. And even in the case of small shrinkage, it remains above this over-counter, leaving a greater space between the soft tissue and the root concavity to be filled with blood clot. And that's why that after a few months, this soft tissue starts to grow in thickness thanks to the maturation of this blood clot. And this is compared to the big concavity that was present before the surgical and the restorative procedure. And this is what more or less histologically we can expect. So the space that was previously occupied by the concavity and by blood clot is now occupied by new connective tissue thanks to the maturation of the blood clot, and the joint of the connective tissue of the flap with the connective tissue of the blood clot is increasing the thickness of the soft tissue. And once the thickness of the soft tissue is increased, you can expect creeping. Creeping means the coronal advancement of this soft tissue that has been increased in thickness above the very, very clean, very, very smooth, and very, very hard surface, like is the composite restoration. And after many years, you can see a further growth and further improvement in the aesthetic appearance and in the profile of the teeth, especially if you compare the situation before. But now, if you want to overlap the two situations in before and after, you can see what is very, very critical is that where there was the sharp interruption due to the abrasion of the enamel is much more coronally displaced with respect to where is now the soft tissue margin in apical and in the buccal and lingual position, namely the soft tissue is more buccally displaced with respect to the enamel, original enamel of the tooth, and this was really impossible if we did not sustain the soft tissue margin at the time of the surgery with our composite restoration. But now we can look at another case, which is the most difficult of all, and is the situation where we have a very deep interruption of the enamel. This is non-carious cervical lesion, but most of the time, from the color of the root, you can see that is almost tooth decay. So you can imagine that after root planing, this will become even much more concave. In this case, we cannot make the composite restoration as we did before. Otherwise, the risk is to create a too much bulky profile of the composite restoration. So we have to make some enamel plastic. Enamel plastic means that some of the enamel has to be reduced in order to create a bevel of the crown and make the finishing line of the composite restoration in the right position, that is just 1 millimeter or even less more coronal with respect to the cement enamel junction of the adjacent lateral tooth. But now we have to open the flap. And we know that after opening the flap, we have also to make root planing. And after making root planing, we have to make a very hard, smooth root surface. And this must be clean until we can hear the noise of the dentin once a sharp curette is used above it, the so-called credentine air. And so we cannot decide when to stop root planing because we don't like to make too much root planing. It depends on the quality of the root. And so in this case, most of the case, we create a concavity of the root with respect to which the composite restoration is even too much bulky, even if too much over counter. And so there is some risk if we coronally advance the flap over this composite restoration that in case of shrinkage, there is still risk of collapse. But in this case, the fault is of the root because it's too much concave. So we have to make something at the level of the root in order to prevent the risk of collapse. This is called connective tissue graft. So the adjunct of connective tissue graft is not to achieve root coverage, but is to prevent shrinkage and collapse of the coronally advanced flap, which remains the true protagonist and the only protagonist of the root coverage procedure, because now we coronally advance the flap, we adapt it in more coronal position with the connective tissue graft, and the connective tissue graft, by replacing the root in a more buccal position with respect to the crown, prevent the risk of soft tissue collapse. And so again, in the sleeping tooth, we can appreciate better what I'm telling you. This is the distance between the enamel and the root. This is after completely change of the shape of the abrasion by making enamel plastic composite restoration. This is after root planing, where we have a big concavity of the root with respect to the over-counter of the composite restoration. The need for a connective tissue graft to replace on a two different level with no more risk of collapse, the root surface by adding the connective tissue graft and the enamel, and finally the coronal advancement of the flap. And this is the overlap, the importance of the connective tissue graft to compensate for the loss of root substance, the coronally advanced flap. What is the first healing? The first healing is that if you notice the central and the lateral, a good amount of keratinized tissue, while the canine is still lacking because it's only 3 months after the surgery. But if you pull the lip of this patient, you immediately see by ischemia how much hard, dense, collagen-rich, attached gingiva there is below. But you can also appreciate the color of this. This is too much white. The patient does not like to see something that is different from the natural appearance of the soft tissue. So since the patient, during the smiling, does not wear the lip retractor again, we can see that the color of the soft tissue comes back and they becomes as much as similar to the adjacent tissue. So the problems of keratinized tissue? No, there is no problem. We have to wait with time because thanks to the realignment of the mucogingival line, you can achieve at the same time increase in the soft tissue thickness, but also increase of the keratinized tissue height. And if you look 2 years later, And if you look at more carefully, what is the color of the soft tissue of the lateral where only the colony advanced flap was performed with respect to the color of the soft tissue covering the canine is exactly the same. Where the alveolar mucosa is finishing at the level of the lateral is exactly in the same level where the alveolar mucosa with its vascularities is finishing at the level of the canine. So the problem of the keratinized tissue is a problem of the periodontist, not of the patient. There is no patient in the world that asks me, may I have some more keratinized tissue? So keratinized tissue is something that we like for the patient to clean, but the patient does not know. The patient does not want to see any difference in color, texture, and surface characteristics between the treated area and the adjacent teeth. And this is the concept in this case. Since of the big concavity at the level of the root, we need some more mature connective tissue, some more mature blood clot, which is called connective tissue graft, that support at the time of the surgery, prevent the collapse, and then the two thickness join together to increase the soft tissue thickness and achieve the final outcome. Again, this is the overlap of the before and after, which in somehow summarize the whole treatment procedure we have to perform for the treatment of gingival recession. And if you overlap the two pictures, you can see how much of the treatment was done. First of all, we make enamel plastic. Then the composite restoration was extended in more apically position, but there is no need for any attachment between the soft tissue and the composite restoration, because the composite restoration is finishing inside the sulcus area where the patient can clean, when the dental hygienist can check, and in the case of failure, this can be done very, very easy. But also the increase in the soft tissue thickness, like the increase in the keratinized tissue, is just limited to the 3-4 millimeters in more coronal. That is exactly the position where we place our connective tissue, because the connective tissue is no more used to achieve root coverage, but it is used just to help the flap to remain stable during the time it takes for the maturation of the soft tissue, for the realignment of the mucogingival line to go back to its original and final position. Thank you very much.